afternoon, everyone, and welcome to today's edition of Black Health Trust. We, as always, are delighted that you chose to spend this time with us. And without further ado, I will turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everybody. I'm always tempted to say good morning, but it must be morning in some place. I thank everybody for joining us. We have an interesting show today. Uh, I've been concerned that all the time we talk about telling people uh, what different disease processes are and what to do about them, but rarely do we tell them what type of expectation to have when they go to the doctor, what the doctor they should be going to, what kind of tests they would be doing, what kind of doctor. So I want to go back to in time and talk about what are the things that you should expect when you see a certain physician, and what are the most important things that affect our community. So we'll have a number of slides, and my co-moderator will be joining me in narrating these slides. Thank you very much, Simon. Can you put up the first slide? And by the way, before the broadcast, Dr. Barbara Davis-Stevens was talking about a TV show that talked about artificial intelligence, which we know is machine learning. So one of the things that was talked about is how these machines do self-learning and self-preservation. And I want to be sure they probably do, but all the more important that we should get knowledge and be a part of the solution and not just wait on somebody else to solve it in their favor and us not be a part of it. Can you put up the first slide, Simon? So we're going to talk about the top 10 medical conditions and that affect Black Americans. We're going to talk about what are the symptoms, what are the signs, what are some of the diagnostic advances that happen. And let's go to the next slide. So I gave artificial intelligence a choice to pick out the most important diseases that affect Black communities. And we know that hypertension is often called the silent killer. And nobody may know they have it. In fact, they say that more than 50% of the people that have it don't even know they have it. But if there are symptoms, sometimes it could be headaches, shortness of breath, you might have nosebleeds, chest pain, and changes in vision. So I put in a category called diagnostic pearls. The way you confirm it is by repeated blood pressure measurements. And we want that blood pressure to be less than 120/80, not 130/80. And you want to evaluate end organ effects, like the effects on the heart, the effects on the kidney, a fundoscopic exam, which is looking into your eyes with what's called a ophthalmoscope. You can look into the back of the eyes and you can see changes in the blood vessels. So when you go to your primary care doctor or internal medicine doctor, they should take this little handheld machine and look in the back of your eyes. They can tell an awful lot by that. And you want to make sure that you get an EKG, which looks at the size of your heart, the amount of electric activity in there, whether the heart's enlarged. You also want to look at a kidney panel or renal panel. And you want to make sure you do urinalysis because many times you'll see end organ damage if there's protein in the urine or cells. Let's go to the next slide.
Before we leave that, may I make a comment?
Of course.
I don't want people to think that hypertension is an old person's disease.
Excellent.
Hypertension is rapidly increasing in frequency in ever younger individuals, especially in our community. And we need to be vigilant, even with our kids, starting no less than at 12, especially if they have any kind of comorbid condition like obesity. We really need to take the a stigma off of hypertension and start treating it as the dangerous condition that it is. Because once you have hypertension, not only do you have the end organ damage that Dr. Maxey just mentioned, but it sets you up with a comorbid condition that will complicate other conditions. And in the younger population, very definitely, it is impacting maternal health. So women going into a pregnancy with hypertension are at an increased risk.
Let me bring up one other thing since you're a pediatrician. And I read this years ago about the time when I first met you, Dr. Neighbor-Steven, that if you were to look at the blood vessels of an infant of a family that had a history of hypertension, those blood vessels might look different and show the first signs of high blood pressure even as a newborn. Is that true still?
They're still researching that, but that there is definite concern about the intrauterine exposure and experience of the fetus, and
And
not only with hypertension.
okay. And Dr. Hines, being a family practitioner, uh, some women have a problem in the peri-birth period, placenta brusha,
Abruptio. Mhm.
placenta, and they also have high blood pressure. Can you just talk about that for a moment?
So, pregnancy-related hypertension is just what it sounds like. It is when you are a person who does not have high blood pressure normally, but during your pregnancy, you then develop high blood pressure. I am one of those people. Sometimes it is managed with, depending on where you are in your pregnancy, that will usually determine what is done about it. Sometimes you do have to start on blood pressure medicines during your pregnancy, and oftentimes for a period of time after your pregnancy. And then if you do have pregnancy-induced hypertension or any of the more serious conditions that come after that, like preeclampsia or eclampsia, you have a greater risk of developing hypertension, regular old hypertension later on in your life. So you should, if you have that in your history, you should be extra vigilant on, periodically checking your blood pressure and making sure that you don't, if you're watching for if you're developing hypertension.
Dr. Maxey, Dr. Lawson has his hand up.
Hello, Dr. Lawson.
I just want to note that many of the same people, there's general recognition that there's something between high salt intake and hypertension, but the same people who go out and try to avoid a high salt diet are the same people who go out and tend to use mega doses of caffeine. One of the things that we see now is a lot of our routine food is getting high doses of caffeine. Some of the drugs of abuse are stimulant medication, and I and others have seen people, young people, teenagers coming in having strokes from having ongoing elevated blood pressure from some of these drugs of abuse, as well as these long-term stimulant foods that they're getting.
And what about the energy drinks?
And that's what I was talking about. And it's not just coffee. Some of these energy drinks, some of them have one. I've seen one with a warning label on it, but most of them do not. And they go over the recommended doses for what is recommended for caffeine. So it's so diet isn't just avoiding salt. It's really looking at at the whole process, and especially young people who think that somehow they're immune to the effects of these high dose medication.
And the other drug that's very hypertensive is cocaine. And cocaine does cause severe vasoconstriction and high blood pressure. Let's go to the next slide. Go ahead, that's awesome.
Someone put in the chat about magnesium helping lower your blood pressure. So having low magnesium is associated with higher blood pressure, and getting your magnesium to a normal level can contribute to helping with control of your blood pressure, which is a little different than I'm gonna just start taking magnesium supplements because I want to have lower blood pressure.
And I might add, there are some TV commercials currently playing that suggest that.
Okay, let's go to the next slide. So, Dr. Hines, you want to talk about this one?
Sure. So first line treatment for hypertension is almost always going to be therapeutic lifestyle change, right? Therapeutic lifestyle change is going to include things like a low salt diet or the DASH diet, weight loss. Even losing 10% of your body weight can cause a reduction in your blood pressure if you have elevated blood pressure. And then regular exercise. Exercise alone, even without losing weight, can also help you lower your blood pressure. So no matter what, even if you end up on blood pressure medications, you should be doing therapeutic lifestyle change.
The other thing I want to say as you talk, people whose heritage goes back to Africa, especially West Africa, tend to be more salt sensitive. So 1 grain of salt with you may be more important than 2 grains of salt in another group that's of European extraction. So you're more sensitive for salt. So not just should be low salt, but understand that salt is more detrimental to diets of African Americans than it might be to others. Go ahead, Dr. Hines.
And to just kind of further that point, if you are really trying to monitor or be concerned about your blood pressure, you should have a home blood pressure cuff, right? Like, because just taking it every once in a blue moon when you're at the grocery store isn't necessarily going to give you a real life indicator of how it is on a regular day when you're just doing your regular stuff. So, and then even in that regard, make sure you have a blood pressure cuff that fits your arm. So bigger people have bigger arms and are more likely to need a bigger, larger than normal standard size cuff. If you've got the wrong size cuff, too big, too small, right, then you are not getting accurate information. There are all kinds of ways now to check your blood pressure. They got finger ones, wrist ones, like all over, but the gold standard is still on your upper arm. And then there are plenty of websites that you can go to that can speak to the accuracy of different home blood pressure monitoring machines. All right, so medication. So oftentimes your providers will start you with what's called thiazide diuretics. That's going to be like HCTZ, or hydrochlorothiazide is one that you might have heard of. That's very popular. Your ACE inhibitors are the ones that end in pril, so lisinopril or those kinds of medicines. Those are your ACE inhibitors. Your ARBs are going to be another class of medicine, as well as calcium channel blockers. A very common one is amlodipine, felodipine. The ending of the names are kind of telling you what kind of category they're in. And sometimes they come in various combinations. The higher your blood pressure is when you get engaged in treatment, the more likely you are to need more than one medication. So if you need to, go ahead.
Let me disagree with my own slide here where it says ACE inhibitors. I typically don't prescribe ACE inhibitors for Black people. And that's because when ACE inhibitors were first developed, they did not have Blacks in the cohorts that were tested on. And there tends to be a high degree of laryngospasm and issues with allergic reactions to people with ACE inhibitors. So I tend to go with angiotensin receptor blocking agents, or ARBs, things that end in sartan. That's just my personal bias.
I would say I'm seeing that in general as well. I'm seeing a lot more African Americans on ARBs before ACEs, and if for some reason they're having a hard time with the ARBs, I'm seeing some people then go back to the ACE inhibitors. You will sometimes see people on ACE inhibitors or ARBs, and your doctor might say it's for kidney protection. That happens plenty. And then, like I was saying before, combination medicines, nobody wants to have to take 3 or 4 pills, right? So if possible, at talking to your provider about combinations, if you are on multiple medications, it also, makes it easier to take and you are more likely to take them. And then
So
certainly,
what
as
is a
Dr.
combination medicine? Explain what a combination medicine is.
So a combination medicine would be like, it's going to have a thiazide diuretic in it, an ACE inhibitor in the same pill. So you might be taking 2 medicines in 1 pill. They have a few that are 3 medicines in 1 pill, but most of them are combinations of 2 different classes of medications in 1 pill. And how you would know that is if when you're looking at your prescription bottle, there's usually going to be a name with a number dash another name with another number, right? That's a good clue that there's more than 1 medicine in this particular pill.
And the other thing is that research has shown, especially for African Americans, to stay below the side effect profile of any one medication. It may take 2 or even 3 medications in combination to adequately control your blood pressure. So that's something to consider.
Yeah.
Okay. All right, let's go to the next slide. Who wants to take this one?
I can take it.
Okay.
And there was a question that just popped up in chat related to this. Metformin is not a hypertension treating medication. Metformin is for diabetes type 2. So symptoms of diabetes type 2, they may develop gradually. Some of the common ones are having to go to the bathroom more frequently to urinate, either during the day or night or both. Drinking more because of more frequent thirst, problems with blurred vision, not having the energy that you used to have, and slow wound healing. Many people are asymptomatic at diagnosis. That's to say that many people don't recognize that they are having symptoms at the time of diagnosis. Diagnostic Pearl, a hemoglobin A1C greater than 6.5%, fasting glucose greater than 126 milligrams per deciliter, or a 2-hour oral GTT greater than 200 milligrams per deciliter. These are red flags, to say the least, that need to be pursued for further diagnosis. And you need to check for insulin resistance signs like a skin darkening, typically cheeks, neck, armpits, called acanthosis nigricans. And Simon, could you scroll it up a little bit, please? You want to screen for some of the end organ complications associated with diabetes, such as the damage to the vessels of the eye, called retinopathy. And I can't see the last part. And problems with the kidneys, called nephropathy, or problems with nerves, which is called neuropathy. Treatments include lifestyle modification and metformin, although I do believe that there is now recommendation that you not start with metformin. Thank you. Early introduction of SGLT2 inhibitors or GLP-1 agonists, which are probably more known now for their weight management properties and cardiovascular impact, in even before people have developed any of the cardiovascular or renal signs and damage. You want to monitor your glucose, and we got all kinds of ways now to monitor the glucose. You don't have to be sticking your finger necessarily. Got the little Dexcom and other products that you monitor subcutaneous little device slapped onto your arm or midsection. Monitoring of hemoglobin A1C, watching out, again, diet changes. You want to make sure your lipids are down, and monitoring of the blood pressure.
I've got two comments. One, there's some recent information that you may have an increase in retinopathy with these GLP-1s. So that's something that you're liable to get with the diabetes, but it could be a complication of the Ozempics of the world. And also, I'm concerned that you want your A1C to be less than 5.7, as you want as low as possible. That correlates with end organ damage when you have a high A1C. Any other comments on this particular slide? Any of you gentlemen, ladies and gentlemen, have a comment? All right, let's go to the next slide. So this is
Okay, this slide we are comparing the prevalence of diabetes type 2, and it is almost twice as prevalent in African Americans as it is in the white population. Some of that is genetic, some of it is lifestyle and behavior, but at the end of the day, this is a very significant problem in our community.
So can you
I'm
talk
sure
about,
people have grown up knowing people that have had amputations. And if they weren't traumatic amputations, more than likely they were related to complications from diabetes.
so can you talk a minute, Dr. Stevens, about type 1 versus type 2 and which one is more inherited and some of the mixed types?
Well, I actually want to step very carefully in that area because the information is changing in that area. Type 1 now is felt to be an autoimmune disease. There does seem, well, the studies years ago had shown that there were some genetics, some suggestion that there was a genetic component to it. When I was in medical school, we were taught that the initiation of type 1 frequently followed viral infections, especially mumps. Now it makes more sense because that's probably an epigenomic impact of the viral infection as opposed to specific damage to the cells in the pancreas. Now, type 2 diabetes is a different disease. It is due to the development of insulin resistance. In type 1, the insulin isn't there because the pancreas is not secreting it. But in type 2, the pancreas is secreting it, but it's not working. And so the pancreas tries as hard as it can for as long as it can to meet the need, but it eventually poops out.
Okay, any other comments on that?
Dr. Hines, did I leave anything out?
Nope, you got the nail right on the head. But yeah, they are discovering other types of diabetes other than the traditional 1 and 2 that we are most familiar with currently. But I wouldn't say it's mainstream information, and it's still they're still kind of figuring things out there. But this is another place where artificial intelligence has been good because a lot of that discovery has come with the assistance of AI and machine-based learning. Dr. Lawson has his hand raised.
Dr. Lawson, go ahead.
Yeah, I just want to know. I've been doing research on this for a number of years, and there are 2 different disorders, but there's also a lot of overlap. Even in type 2, the presence of the exogenous insulin does lead to an autoimmune reaction to it. And also, I found that it's not just an issue of the pancreas. The receptors that are involved in the pancreas also, you see the changes in the glucose receptors in the tongue as well. So that taste preference is different for the two populations as well. I might also add that there's mentioned that another risk factor associated with diabetes is, of course, depression, and that we find that depression is much higher in people with type 2 diabetes than it is in the general population. What comes first, with the chicken or the egg, whether depression leads to overeating and so forth, versus vice versa, is not known. But the fact is that they do often co-occur.
It sounds like all parts of the body work together, huh?
It
Imagine
would seem.
that.
Let's go to the next slide. We only have one psychiatrist today.
We got two.
We have two?
We have two. The esteemed Dr. Ivan Walks is in the house.
Dr. Walks, how are you? Is he muted?
Yeah.
Okay. Let's go with chronic kidney disease. So the symptoms, the early symptoms often are not there at all, but you may have fatigue, nausea, anorexia, which is no appetite at all, itching, which is pruritus, swelling in your legs especially, and altered urine output in advanced stages. Diagnostic pearls, you have a lowered estimated glomerular filtration rate, which is less than 60. You want that to happen for more than 30 days, or your albumin or protein in your urine greater than 30 for at least 3 months. And we want to monitor the protein in the urine. It's called the albumin creatinine ratio, and that's very important. When you go to your doctor, they need to make sure they order urine either in the office or from the laboratory. And you want to monitor the creatinine. That's a blood value that goes up if your renal function goes down. And that's something you want to be conscious of. Know what your creatinine is, or your EGFR, or better yet, what your ACR is. And also, they may order tests for your kidney, look at the size of your kidney, which is a renal ultrasound. They might also look at a renal nuclear scan, which shows how urine is moving through the kidney. And they might also do an MRI of your kidney. And now that's a more preferable reason than even the ultrasound. They can tell that by the texture of your kidney if there's any fibrosis or scarring of the kidney, which is one of the main things that causes kidney disease. Any comments on this, doctors?
Oh, one of the things that at the beginning of this talk, we said we were going to talk about the different specialists, and we have not identified some of the specialists that you would see with some of these conditions. So I'm just going to go back a minute and say there are for hypertension, there are hypertension specialists, and they'll usually get involved for people whose blood pressure is difficult to treat. So they're usually like a part of, either they could be under the cardiologist group sometimes there are different types of internists, but a hypertension specialists do exist. And then for diabetes, if you end up needing
mostly nephrologists.
Well, that too. I was going to get to that in the but yes, because of the link between kidney disease and hypertension, oftentimes, to Dr. Maxey's point, nephrologists or kidney specialists are involved too. And then for diabetes, endocrinologists are where oftentimes the diabetes specialists as far as doctors are concerned, but then there are diabetes educators, there are nutritionists who get involved, because there are so many end organs that you're checking on. Podiatrists, the foot doctors get involved, the ophthalmologists, the eye doctors get involved, again the kidney doctors get involved. So diabetes often comes with a number of different specialists that you might be recommended to see. And then back to chronic kidney disease, again, the nephrologist. And sometimes people mix nephrology with urology because it seems like it's the urinary system, but there are two different things.
Excellent.
So let me add to what Dr. Hines just said, the mental health aspect of it, because any of these chronic conditions can be made worse through either a mental health diagnosis that makes it difficult for folks to comply. And we think that sometimes people don't comply just because folks don't comply. Sometimes folks don't comply, and it has to do with their depression or with their ability to pay attention. There are a lot of reasons that mental health should always be one of the things that is considered by both the practitioner and the patient when you have a chronic illness that may not seem to be responding quickly to what the doctor or the practitioner thinks it should be responding to.
Thank you, Dr. Walk. What row you sit on today?
I was in the back today, Dr. Maxey, but I paid attention.
Okay, let's go to the next slide. Okay, it was a slide on CKD I thought before this one. Go back. Go back one. Okay. Okay, the graph, this one. So this shows that there's more chronic kidney disease in African Americans than in the general population. So most of us know that. We know that Blacks make up 13% of the US population, but they make up more than 30% of the population on dialysis and even more with CKD. And part of this, again, is genetic, and part of it is lifestyle, and part of it is complication with diabetes, which is the most prominent cause of kidney failure or kidney problems, and second is high blood pressure. So all these are related.
You know, I want to bring up a point, and I don't have I usually like to try to ask a question when I kind of know the answer, but I really don't know the answer on this. So, with the new changes going into effect with both Medicare coverage and Medicaid coverage, we need to be very vigilant on the point of access to dialysis in our community. I don't know if anyone has any specific information about that, but I do know that this is a service that we utilize heavily and is a potential area where access can be uh, significantly impacted with deadly consequences.
I think you raised a very important point. With the need for dialysis, we know there are several types of dialysis: hemodialysis, peritoneal dialysis, and then there's renal transplant, all of which are very expensive. And the companies that are made to do these require a lot of reimbursement. In 1972, the first government sponsorship of dialysis started. So even though we talk about being a capitalistic country, we know that we're socialists in the sense that some of these chronic services are paid for by the U.S. government. We know that the current administration is making an attack on everything that spends money. And we know that the average person of low income could not afford dialysis without government support. So Dr. Nabors-Stevens is exactly right. These services are probably under the microscope right now. We're trying to cut government funding, especially for the people who need it most. So you'll find that if you need something more than other people, it'll be less available. So that's something we have to keep our eye on.
So to your point, some of the things that are proposed are increased out-of-pocket cost, new Medicaid co-payments, such as a potential $35 per treatment copay for dialysis for CKD patients above the poverty line. The Medicaid cuts to eligibility with regard to work requirements could also potentially impact kidney patients, and the reduced funding could limit funding for dialysis clinics, particularly in rural areas. And certainly the barriers to ACA enrollment and automatic re-enrollment could delay and cause particular difficulties.
Thank you. Good.
Let me add something here, Dr. Maxey. When this slide came up, Dr. Neighbor-Stevens mentioned that we can look at genetics and we can look at lifestyle. And I think that every time we say genetics and lifestyle, I think we have to add access, because we have a significant problem with unequal treatment. That's what it's been called historically when it's been researched. There's clearly an ongoing issue with unequal treatment. And I think that we have to continue to call that out. It's not, in addition to genetics and lifestyle, there's a significant treatment component when we look at all of these chronic unequal treatment component when we look at all of these kinds of challenges that differently impact our community. And one additional comment, when the mention was just made of work requirements for Medicaid, work requirements sound like a reasonable thing. If you're able to work, you should go to work. The problem with work requirements, like so many great ideas, is implementation. Because when they've tried to put work requirements in place, they failed, not because people don't want to work, but because the systems aren't user-friendly or even sometimes usable for you to document your work or your efforts to find work. And so people can't stay on the roles they need to stay on, not because they don't want to work, but because the systems that are put into place don't work. So if I sound a little bit terse about that, I'm tired of us. I'm tired of people saying that, well, folks don't want to work, and that's why work requirements are onerous. Work requirements are onerous because people don't know how to put work requirements in place so that they're usable.
I'm thinking all
End
the
of my sermon, Dr. Maxey.
government who are put out of work and will lose their insurance. How will they fit in? They'll no longer have private insurance, no longer have access, and they want to work. So I think what you say is very important.
Could I
Dr.
also just
Lawson has his
add?
hand up.
Could I
Yeah.
also just add real quick that so I can give a comprehensive aspect, not just the potential negatives. There are some potential positives that could come out of the new changes. There is an increased focus on home dialysis, and the administration is also potentially pursuing improvements to the transplant system, which is rather complex as well. And then obviously the promotion of prevention, wellness, earlier detection, those things are also proposed changes for the good. So I just want to make sure I'm giving a comprehensive response. Sorry.
Let me add to that, Dr. Hines. It's a very good point. So in home dialysis, there are two types. One is hemodialysis, which is they put a shunt in your arm and access your blood through a needle. And the other is peritoneal dialysis. Most nephrologists will tell you that we don't recommend home hemodialysis as much as the government wants to do. There are emergencies that happen that unless you have a nurse with you, you may not be able to handle that. If you're going to do home dialysis, we recommend peritoneal dialysis where there are no emergencies. So something to be seen. Don't get put on home hemodialysis and you have a teenager at home who doesn't know CPR. That's something we need to look out for. It's not better that way. Next slide.
Dr. Lawson has his hand up.
Dr. Lawson? Dr. William Lawson?
I think Dr. Lawson is trying to unmute at the moment. There we
Okay,
go.
I just want to follow up again in terms of what Dr. Walks has already stated. The question is, why is it we have lifestyle requires important? We're saying we have work requirements. Why don't people want to work, and why don't people want to do the right things in terms of the lifestyle? One of the biggest factors is depression, which is often grossly under-recognized in our community. Now it's grossly under-recognized, but people don't want to be told that they're crazy. So the result is that we have a lot of people who are at home, who are not working, who are just resistant to the lifestyle issues. And the real issue underlying it is that these people are depressed. Not sad kind of depression, but depression in which they have no energy, don't want to go out and take a run, don't see the point of doing all this work to try to deal with life. So in the back of any primary care provider or any specialist should think about is, why is it that your treatment isn't working? Why is it that your recommendation isn't working? It's because many of these folks have chronic, unremitting, untreated, unrecognized depression, and often what we found, a lot of people have trauma. Just again, showing our research showed that 50% of African Americans that seeing primary care providers suffer from either depression or some sort of anxiety disorder.
That's a large number, Dr. Lawson. Why don't you take the next slide, if you would. Dr. Lawson?
Cardiovascular disease, symptoms, chest pain, angina, shortness of breath, palpitations, dizziness, and fatigue. Women may present with atypical symptoms like just jaw pain or nausea. Diagnostic pearls, EKG, and troponin for acute chest pain, echocardiograph for structural assessment. And I don't have my system.
Stress testing.
There you go. Stress testing or coronary CT angiography. Well, can you slide it up a little bit? There we go. Thank you. Anxiety for evaluation of ischemia. Lipid panel, HSCRP, and coronary calcium scoring are useful in risk stratification. Treatment, lifestyle changes, diet, smoking, cessation, exercise, which many folks don't want to do if they're depressed or anxious, aspirin in select patients, statins for lipid control, beta blockers, ACE inhibitors, and nitrates for ischemia. Revascularization with PCI or CAPG, if indicated, cardiac rehab post-MI. And now I'm going to post-stroke depression.
Thank you. Any comments on this side?
I think that we can spend a lot of time focused on some of the challenges that are likely more prevalent in the African American community and in many diverse communities. For example, when we talked about the fact that folks may not do the exercising because of depression or anxiety, and in addition to that, folks may not have a place to exercise. Many communities are not safe to go out walking around at certain times. And when I say certain times, it could be noon and bullets are flying in certain areas. So exercise inside. Well, maybe if I live in a multi-unit place like an apartment building, any sort of movement up and down can be disturbing to other folks and can cause complaints. So I think that part of the reasoning, part of understanding the reason that folks aren't compliant certainly includes looking out for depression, looking out for anxiety. It also includes having conversations about, are the facilities available for the person who you want to exercise more? Because it's easy to say, well, you can go walk in the mall. Well, maybe you can go walk in the mall. Is there one close by? Can you get there? These look like simple, straightforward questions in many suburban areas, and they're not as straightforward questions and answers in many parts of our community.
Hey, Dr. Lawson, will you take the next two slides?
You want me to take the next two slides? Dr. Lawson only had to take one. Why? Okay.
He's your senior.
He knows a lot more. That's why I'm complaining. Cardiovascular disease, prevalence comparison. African Americans, much higher prevalence of cardiovascular disease than in the white population
Let's go to
for
the
a
next.
lot of the reasons that we talk about. Asthma, symptoms of asthma, recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, particularly at night and or early morning. Diagnostic pearls. Spirometry shows reversible airway obstruction. Peak flow variability, more than 20%, confirms the diagnosis. Allergen testing may help identify triggers and rule out chronic obstructive pulmonary disease in older adults. And then we need to scroll down a little bit if we can. And while we're doing that, I'll just emphasize the one little part up there where it reads reversible airway obstruction. So with asthma, you have reversible airway obstruction. Treatment, stepwise approach. Inhaled corticosteroids are first line treatment. Add LABA or leukotriene modifiers as needed. Rescue inhalers for acute symptoms. Biologics, for example, anti-IgE for severe eosinophilic asthma. Avoid known triggers and use action plans. I remember, Dr. Maxey, you'll mention from time to time that I was the chief health officer for the nation's capital. And I remember when I was in that job, and it may still be true, the number one reason that kids missed school and had to go to the emergency room was asthma. So asthma is a big deal in many of our communities, and it's not an uncommon interrupter of schooling for kids and, of course, by extension, work for adults who have to leave and take them places and react to the challenges they have.
So to finish your point, making it on this slide, Dr. Walks.
Okay, asthma prevalence comparison. Dr. Maxey, do you have any slides that show that we're doing better? I might need to go see Dr. Lawson for some depression after looking at all of these slides. It is tough. Asthma prevalence comparison, African Americans, way higher than in the white population. And again, we may want to talk about lifestyle and genetics, and at the same time, a lot of us live in areas where our lungs are under assault from just the places where we have to live and the conditions in which we have to live. So I'm not claiming any of this. I probably should, but I'm not claiming any of this difference as something that is either inherently in our genetics or inherently in our unwillingness to act right. I think that we have to always consider the differences in the resources and in the load that is put on us when we look at all of these chronic conditions.
Yeah, I think there's a reason for this, and that's the point I want to get to, is where we live and what we're under stress for and what we call allostatic load that we have these conditions. So I think we should probably stop for today and we can pick the rest up because I had 10 conditions that we went on these. So let's just discuss these with the top of the hour. But the main thing I wanted to do is point out how many problems that we have to address. And most of them do start with paying attention to yourself and lifestyle. So we're going to ask for people to make final discussions and comments, and we'll pick this up in the following week, go through the rest of them. I was going to say the youngest among us is Dr. Hines to start us off on any discussion that she wants to have.
So I think that sometimes when you get diagnosed with some of these chronic conditions, there is this tendency I found for people to, get up in arms and feel like their body is failing them, right? And sometimes that place keeps them from taking the action steps that they need to take. And it's not, I would, suggest to not think of it quite that way, right? Sometimes assistance is needed all around, right? Whether you're younger, whether you're older, in different ways and in different forms, it's just assistance is needed. And I would not underestimate the value and importance of therapeutic lifestyle changes. In some instances, there are several of the conditions that we discussed. If you are able to, willing to, have the capacity to make appropriate therapeutic lifestyle changes, those things can lead to reductions in medicines and sometimes not being on medicines. Therapeutic lifestyle change is a treatment in and of itself. So.
One of the things you reminded me of, what made me come up with this topic today, is I had 2 patients referred to me in the past 2-week period. And one was a gentleman who was 68 years old, and he had prostate cancer. So I asked his daughter how long he had prostate cancer. She said 28 years. So he had failed 4 different treatments for prostate cancer over 28 years, and nowhere went to get definitive surgery or actual good treatment for it. And by the time he got referred to me, he had metastasis to his brain, to his lungs, to his bones, etc., because his family or he didn't take it serious enough to get the appropriate diagnosis. Another one was a young lady who was 62 years old, and she had felt weak and having difficulty walking. So she laid in her bed for 2 weeks at home, and nobody really checked on her. Turned out she had rhabdomyolysis, the destroying of the muscles in her legs. She developed kidney failure. She developed pneumonia. Again, she did not pay close enough attention to what was going on with her. She just thought if she laid down for 2 weeks, it'd be better. So that's why I wanted to go to some of these things that we have many, I won't call them self-inflicted, but things that happen because we don't have access or don't know enough to just wave it off. Take things seriously and take preemptive care of yourself. Dr. Lawson.
I want to again make the point I was making earlier. There's a disorder that they had in slavery time called dysophica ethiopica, basically saying the slaves were lazy. It's good news that we recognize that some of these disorders aren't simply a result of bad genes, although there are some people trying to say that we have weak, bad protoplasm. But the other part of it is when we start talking about lifestyle and you create barriers towards developing a positive lifestyle, it's not, we need to recognize that it's not just, you can blame the victim, but if you don't have access to exercise, if you put out the message that doing too much exercise is bad for your body, that you limit such activities in youth, that you don't have grocery stores in your neighborhood, so forth and so on and so on, that all of these disorders will lead to the same result. We talk about access to Medicaid. The system is set up so that there's no such a thing as chronic disease. You get treatment for a while and the payments stop. We need to recognize that these chronic diseases, many times needs some sort of lifetime intervention, and the Medicaid mechanism can be one way to support that kind of intervention.
One of the reasons that slavery among African Americans was so popular is that African Americans or African slaves were the only ones who would survive the heat and the workload. And so we were more physically strong. And that led to the system that we now have of denigrating the results of that for so long. Dr. Walks.
Okay, so we have to follow on to what Dr. Lawson said. There are, and it goes back to when Dr. Hines shared with us some of the content of the policy proposals, and did an even-handed job of saying these things might actually, some of these things might actually be on a positive note. I talked to someone who had been, I was kind of surprised this is still happening, who had been let go from their physical therapy. And they were let go from their physical therapy because they weren't making enough progress. And it occurred to me, I know that can happen, but it wasn't that the person wasn't going and the person wasn't making an effort, but their depression was really making it hard for them. And they were in treatment with somebody for the depression. But we sometimes our practitioners are depending on one part of our treatment to work so we can do the other part of our treatment better, and they can get impatient with us. So I'm looking at this person, saying to myself, well, what the heck are you supposed to do? If while you're working on your depression and it's making it so hard for you to follow through with some of the physical therapy that you need to do so that your other healthcare problems can be better addressed, including your chronic pain, which is contributing to your depression. And sometimes, even as a physician, as a practitioner, I have to just step back and go, wow, our non-system that folks are so often exposed to is just challenging. And so we need to do things like Black Health Trust and call out some of the challenges that are there. We need to let people know that they are not alone when they're struggling with these challenges. And I don't want to rile up my dear friend Dr. Gibson by talking about how much the pharmacies are involved with just trying to do what they're trying to do while these large companies are making all these decisions about what they can fill, they can't fill, how often they can fill it. Even if you have money, you can't buy this because you can only buy it if you have insurance, but you just lost your job, so you lost your insurance, but now you can't get the medication that the doctor thinks you need. It is, I need another slide just to help me calm down when I think about all of the challenges that we have and the folks that we're trying to keep healthy have in our society. So that's my rant for this afternoon, Dr. Maxey.
Let me respond to what you just said. I remember the other day, I try to walk every day. But if I go out to walk and a lot is on my mind, especially things that might not be so happy, I'm not depressed in the psychiatric thing, I don't think, but it will determine how far I can walk that day. I can't do it. And your mind is very powerful, and when it's not hitting on all 8 cylinders, it can definitely affect even something as, do I really want to walk 2 miles today? Maybe I'll just walk a quarter mile. And that will determine the energy that I have. So I know what you say is very true. The famous Dr. Barbara Davis-Stevens.
I don't know about how famous, but I'm going to end today with a reminder of something that we discussed maybe 6 weeks ago now. Time flies for me. And that is all of the conditions that we discussed today are impacted by heat. And so I just wanted to remind people, anybody who has any of these conditions, or even if they don't have these conditions, heat is no joke. And I can't help but wonder if the patient that you described, Dr. Maxey, got into trouble because of heat. I don't know, and I'm just saying that heat alone could have put her in the situation that she was in. And it definitely impacts everything that we talked about today and then some. So please, everybody, even if you are into the mode of, I'm not going to watch the news anymore. I'm not going to even get off into that now. But please watch the weather at least once a day and be aware of what's going on in your environment, and then execute the strategy that you have put in place, your plan that you have put in place on how you're going to manage heat during the times that we're going through.
Well, thank you so much. Let me tell you why you're my hero. At the National Medical Association, I went to the President's Ball, and people were dancing, and Dr. Neighbor came up to me and she was showing me how to do something, and people were doing some kind of line dance that I don't know how to do. And she would pull my sleeve and make me turn at the appropriate time and made sure I didn't fall down. I really appreciate you so much. Have a great day, everybody. Thanks for joining us, and we'll continue with these slides maybe next week and talk more. Thank you.
Bye.
Simon.
Good day, everyone.